Hi guys, this is Emma and I'm just going to be doing a small presentation over the aging gastrointestinal system. So this presentation is going to be going over the geriatric population. We're first going to be beginning with just a quick review over the system and the function of the GI system. And then we're going to look over the changes in this population, what we need to assess with them, the pathophysiology, and disease processes that are important in this population, as well as a few education points that I think need to be made. So I hope you guys enjoy. Like I said earlier, we are just going to start with the structure and the function. So with the GI system, of course, we're going to start with our intake of food, which will play into the mouth and then followed by the esophagus. Both of these are very vital in the ingestion of our food. Obviously, the mouth is going to intake, mechanically break it down until we are able to swallow it, which will then go into the esophagus and then get into the stomach. Once it made its way through the stomach, it's going to go through the intestines. And of course, both of these are very vital with digestion and absorption of our food particles. The stomach's going to do most of the digestion, but the intestines do have a role in that as well. I also noted that we do have a couple organs that do play into it. The liver does have very many different functions, but with the GI system, it helps metabolize those carbs, fats, and proteins. And then we also have the pancreas, which, as y'all know, because we've gone over diabetes so many times, the pancreas is going to release insulin and glucagon, into the bloodstream just to help regulate the blood sugar. And then also, I did note the gallbladder is used in the digestive system, but I don't think it's as vital as the other two accessory organs. So next is just a small little recap of what our GI system does. Obviously, it is a large system, but it is mainly responsible for our intake of nutrients as well as getting those nutrients out. So I just wrote a couple ways how it does that, as well as the definitions. So it'll start with our ingestion, digestion, absorption, and the elimination of them. Next, we're going to be talking about the many different changes in the elderly GI system. Of course, we're going to start from the top, so that means we're going to talk about the mouth, which starts with our loss of teeth, which can also bring the use of dental implants such as dentures, and can cause difficulty chewing if patients aren't able to afford those dentures. We'll also have a loss in our taste buds, which can mean that we won't have a desire to eat because food won't taste as well. Next is the esophagus, which kind of has a difficulty contracting as well as it did in our younger days. Our lower esophageal sphincter will start to kind of have this distress as the pressure decreases on the sphincter and the motility decreases as well. This will cause our dysphagia and the potential for aspiration, hiatal hernias, and GERD as well. Our stomach will start to atrophy, which means that it can bring on food intolerances. We won't be able to eat the foods that we like as much as we did when we were younger. The intestines will have a slow intestinal transit and will delay the absorption of fat-soluble vitamins. Continuing on, we're going to talk about the pancreas, which will have impaired fat absorption and decreased glucose tolerance, which is why a lot of patients develop diabetes mellitus type 2 when they're older. And then the liver will start to decrease in size and decrease protein synthesis, as well as patients will not be able to metabolize their drugs and the hormones as well. All of this information and more is taken from our lovely MedSurg book on page 840, table 38.5, if y'all want any more information. So next we're going to begin our assessment of the GI system with our subjective data. First, of course, we need to get a health history. Have they had any abdominal pain, nausea, vomiting, diarrhea? Have they noticed any changes in their appetite or their bowels? We need to know what they are in for and the symptoms as well. If we could get a medication list, that would be great, but if not, we need to get the patient to verbalize their medications. This could be prescriptions, over-the-counter, herbals, and we need to know why they are taking them. Of course, some of these medications can be causing the signs and symptoms that they are in for and complaining about. Surgery or past treatments, we need to know, hey, maybe they had a possible bowel resection, and that's why we're having difficulty hearing on one side of their abdomen. Nutrition, what do they eat on a day-to-day basis? Are they having enough fiber? Do they have enough fluid? Maybe they're drinking too much caffeine. Have they noticed any changes in their appetite? And then elimination, basically we got to talk about their poop. What is a normal bowel movement for them? Is it dark? Is it light? Is it formed? Do they not have one for a couple days? We just kind of got to be nosy. A couple other things that can play into the GI system is exercise, sleep, they have any cognitive issues, and of course stress can really get your bowels moving. If we feel like we have gathered enough subjective evidence, we are going to move on to objective. So we need to conduct a physical examination. I personally would start from top to bottom, but of course it depends on the patient and you might have to just do a focus assessment, hit the ground running. So if you were doing it top to bottom, I would start by inspecting the oral cavity. Let's look at the mucosa. What color is it? Are we missing teeth? Do we have bad breath? Is our gag reflex intact? Of course, with elderly patients, they might have dentures, and we need to also assess if those dentures are in place and fit well. And then next we're going to inspect the abdomen. So we're going to look for skin changes. Is the umbilicus in the right position? Do they have a weird contour of shape? And then auscultate it. You always auscultate it before you percuss, because of course percussing it can affect your bowel sounds. So make sure to listen to your bowel sounds for 2 minutes in all 4 quadrants. Then we'll percuss. With the use of percussion, we can help estimate the size of organs and determine if they are enlarged, if there's any fluid where it shouldn't be, mass, if they're distended for any crazy reason. And then palpating it. This can be done lightly, or of course we know we can do deep palpation. So palpitation, is used to detect tenderness if masses are swelling. And we might have to get up in their business. So we might have to ask them if we can examine their rectum and their anus. We can first, of course, just palpate the outside for tenderness or abnormalities, or we might have to get on up there. Just a couple of disease processes that are usually common in this age population. So with the upper GI problems, most of the time they're going to have discomfort with the esophagus. So this can cause dysphagia, GERD, or they can just be nauseated and vomiting. And then lower GI issues can range from anything from Crohn's disease to irritable bowel syndrome. They can be constipated, or they might be impacted by how long that bowel's been sitting in there. We just need to listen to their bowels. Lastly, just a couple of things that I think are very important to be noted with family members and the geriatric population. This population is obviously prone to having constipation or any GI motility issues with elimination. So they need to be drinking enough fluids and they need to be getting their fiber. If not, this can lead to complications. With the aging mouth, it is also important that oral care is done. As a dentist daughter, I cannot tell y'all how many times people come in and they're losing teeth regularly because they're not brushing their teeth. And I know dentures are expensive, so it's also important to inform them that they need to be using that fluoride. They need to be flossing unless they want to be losing teeth. The use of exercise can be important on many systems in the body, but with exercise it can help your bowels move, which means poop. They also need to be taking their medications as prescribed by their physician. Of course, these can cause some adverse effects, so they need to notify us if they are having any of those adverse effects. And lastly, and I think most importantly, is constipation is not a normal part of aging. I've gotten this fact from our little gerontology book itself. Now, it is normal for our body peristalsis in the intestines and stuff to decrease with age, but usually constipation is caused by a side effect of medication if you're inactive, if you're immobile, or you're not getting enough fluid. This is not caused by aging, and I think that patients need to know that. Lastly, of course, it's going to be my resources. I just want to thank y'all for listening. I hope you gained some knowledge on the GI system in the gerontology population, and that y'all have a great rest of the day. Thank you so much.